Let's start with some of the upper limb MCQs and then we'll move to the lower limb MCQs. The first question says internal bleeding can be a rare complication of a broken clavicle if the broken bone fragment becomes significantly displaced and tears a vessel and punctures the pleura. Which of the following vascular structures is particularly vulnerable in a displaced clavicular fracture? So that is the question, basically the last line over here. Options you can see: subscapular artery, cephalic vein, lateral thoracic artery, and the subclavian vein. So what happens is the question is trying to test the knowledge is basically, do we know the relations around the clavicle? This is the sternum over here. We should know that the first rib is attached onto the mandibular part of the sternum, goes behind into the T1 vertebrae. Over the first rib, you have what? You have the subclavian vessels, right? These are the vein will be in front, behind there will be artery. So there will be artery behind and vein in front. But overlapping the first rib, the subclavian vessels, is the clavicle over here, going to the from the sternal end to the acromial end. Okay, so therefore the subclavian vessels are just underneath the clavicle. Though it's a rare complication, but yeah, it can be there. So in the options, if there is any options like subclavian, you should go with it. And here we can see the subclavian vein, option number D, that is the correct answer over here. Subclavian vein, most probable answer. Other option, subscapular artery, is basically a branch coming from the third part of axillary artery, so its location is somewhat over here. Cephalic vein is a superficial vein, subcutaneous vein, and therefore it is lying on the skin, and it drains into the axillary vein, not the subclavian vein, after piercing the clavipectoral fascia. The lateral thoracic artery again will be a branch of the second part of axillary artery. It will be slightly over here, that will be going down and supplying the lateral quadrants of the mammary gland of the breast and the lateral thoracic wall. So therefore subclavian vein is the probable answer over here and the best possible answer. Let us see and the question over here. Axillary artery, now another question from the artery. The axillary artery has become progressively occluded due to the P minor muscle. Which pair of blood vessels would most likely provide a significant collateral circulation around the blockage? Okay, here are all the options. So the basic point over here which we need to understand is that we have this as a, imagine the subclavian artery and then continues as the axillary artery. Axillary artery is divided into three parts by the overlying P minor muscle. So behind this P minor is the second part, first part, and this is the third part. Now they are saying the question that the second part of axillary artery has become blocked over here. What actually happens is the vessels from the proximal to the blockage, or you can say proximal part of over here, and the vessels or the branches from the distal part over here, the anastomose around the bony structure over here. Now which bony structure? You need a great surface area for the anastomose of the vessels. So the bony structure over here behind is the scapula. So there's the scapula, the bone we all know, a part of the shoulder girdle. So these vessels, the anastomose around the scapula, and their names have the word scapula in them. Just a second. Right, their names have the word scapula in them. So what happens is from the subclavian artery, we have the suprascapular vessels, suprascapular or the dorsal scapular as well. And from the terminal part of the axillary artery, we have the subscapular. And its branch circumflex scapular. So these are the ones which will actually anastomose these ones and these ones around the bone, and they will provide the collateral circulation if there is any blockage in between these vessels. Now let us look at the options. Look at the options A, B, C, and D. I hope option C fulfills our criteria. Subscapular artery from the axillary and suprascapular from the subclavian, they will be forming collaterals. If you look at the other options, option A like posterior circumflex and anterior humeral circumflex, they are both branches from the third part of axillary artery. Subscapular, posterior, again both are branches from the third part of axillary artery. So there is no point because already blood is not able to reach directly into the third part of axillary because the blockage is in the second part. The fourth option, third is the answer. Fourth option is lateral thoracic, superior thoracic. They are branches from the axillary artery only, but the proximal parts of axillary artery. So they may anastomose, but that won't help, right? Therefore, answer is option number C over here. Let us see more questions. Innervation to the rotator cuff muscle that medially rotates the arm is provided by which of the following? So they are rotator cuff muscles, and they are asking you that medially rotates the arm. So we all should be knowing rotator cuff muscles. And if you look at the humerus also, we have this as the humerus, the head of humerus, just going down like this. Anteriorly, we have the lesser tubercle, and at the top and behind, we have the greater tubercle. So this is lesser tubercle, and that is the greater tubercle. All the rotator cuff muscles are actually attached on the lesser and greater tubercle. The muscle attached over here is the subscapularis, And the muscle attached on the GT, great tubercle, we all know the SIT. Supraspinatus, infraspinatus, and teres, MI dot minor. Right? Now, they're asking you in the question which medially rotates. The muscles which are attached on the anterior surface of the humerus, they can only medially rotate. Only those can medially rotate. Out of these options, you can see the lesser tubercle lying anteriorly, and the subscapularis, it will medially rotate, while infraspinatus, teres minor, they will laterally rotate, and this is present actually at the top. So it helps in abduction. Initiation of abduction is done by supraspinatus. So therefore, we know the muscle is subscapularis. Now, what they are asking the question is innervation to this subscapularis muscle. We should know it is supplied by both the upper and the lower subscapular nerve, and therefore this should be our best possible answer over here. So we should know basic fact: the muscles attached anteriorly on the humerus or the femur or any limb bones, they will do the medial rotation, and the muscle attached on the posterior surface, they do the lateral rotation. Let us see more. Which does not occur in median nerve injury? Simple, straightforward question. You should know the answer of it. If you look at the options, loss of function of index lumbrical or middle finger lumbrical, we all know that there are 4 lumbricals. The lateral 2 are supplied by the median nerve. These are the lateral 2. So obviously there will be loss of function of these in median nerve injury. They are asking you which it does not. Effect of thenar, do you know that median nerve supplies the majority of the thenar muscle, so that will also be affected, except a muscle that is adductor pollicis. So this won't be there, because adductor pollicis is supplied by the ulnar nerve. So there won't be any loss of adduction of thumb. Even we know in the ape thumb deformity, when the thumb lies parallel to the other fingers, that is a feature of median nerve injury. So this will be our answer, loss of adduction of thumb, because adductor pollicis is supplied by the ulnar nerve. Clear? That was a straightforward question. I hope you know about it. And the boundaries of the anatomical snuff box include the following, except, and again comes the word except over here. So anatomical snuff box is a concavity on the lateral side of the dorsum of the hand, which are this area is bounded by the tendons of the muscles. Now these tendons are obviously coming from the extensor of the forearm, right? So there are few tendons. Laterally we should know few tendons are there, and medially also there is a tendon, right? Laterally we have the abductor pollicis longus and extensor pollicis brevis. These 2 tendons lie lateral. They are the lateral borders. The medial border of this snuff box is formed by a tendon of EPL. These 3 are the tendons which are forming the boundaries of the anatomical snuff box. We should know by now that this box, the major content of this box is the radial artery. That is the major content of this anatomical snuff box. So lateral boundaries by these 2 tendons and medial by this tendon. So obviously the 4th one should be the answer. If we look over here, option number A, abductor pollicis brevis. It is abductor pollicis longus. So here this is forming the medial and these 2 are forming the lateral borders, right? So content is radial artery, and this anatomical snuff box is a very basic question, and questions do come over. And the question then, examining the muscle function at the metacarpophalangeal and proximal interphalangeal and the distal interphalangeal joints. So what findings do you expect in the presence of radial nerve palsy? An interesting question. We have 5 options this time for better understanding. They are saying that you are examining the metacarpophalangeal, the PIPs and the DIPs, and there is a radial nerve injury due to any cause. Could be a fracture of humerus, could be anything, but there is a radial nerve palsy. What would you expect to see? Will there be inability to abduct the digits, adduct the digits, inability to extend the MP joint only, inability to extend the MP, PIP and DIP, inability to extend the PIP and DIP joints? What's the best possible answer over here? We should know over here that if we look over here, suppose this is a metacarpal, and there are this proximal phalanx, middle phalanx and distal phalanx, right? We have a metacarpal and the 3 phalanxes. What happens is the tendon which is coming from here in the extensor department, we all know is the extensor digitorum, ED. As soon as it crosses, this is our metacarpophalangeal joint, this is the PIP joint, this is the DIP joint. Proximal interphalangeal, distal interphalangeal, metacarpophalangeal, or MCP joint. So as the ED passes this MCP joint, we all know about the winged tendons over here. The winged tendons are the lumbricals and the interossei. They will come around and they will form this expansion of this tendon, and that is known as the dorsal digital expansion, right? So that is known as what? Dorsal digital expansion or extensor digital expansion, whatever you want to call it as. Dorsal means extension. Now they are asking you radial nerve palsy. Now radial nerve gives off a branch known as posterior interosseous nerve, which will supply this extensor digitorum muscle, right? So there will be palsy of this particular extensor digitorum. But will that lead to entire palsy of the distal expansion is not a correct statement. Why? The reason is the introitias are supplied by the ulnar and the lumbricals are supplied by both ulnar and the median. Introitias are supplied by the ulnar, both the dorsal and the palmar introitiae, and the lumbricals are supplied by the ulnar and median. So this activity in the interphalangeal joints, their extension will not be completely lost, because extension in the interphalangeal joints is done by both the introitia as well as lumbricals. We must have seen a lot of times that this is the action of lumbricals. Pen holding position, this is the action. When we are doing this, we are actually extending the IP joints. So lumbricals help in extension of this. But when you see the lumbricals, it is flexing the MCP joint. The MCP joint can be extended by only the extensor digitorum, that is supplied to the PIN, which is a branch from the radial nerve. Therefore, there will be definitely a loss in the extension of the MCP joint. Yes, there will be weakness over here. Now, if we come to the options, they are saying inability to abduct and adduct. Now, we all know the pad and the dab mnemonics. Pad and the dab mnemonics. The palmar introitia, they adduct, dorsal introitia abduct. And these introitia supplied by ulnar nerve. So, there will be obviously no inability of these. When they are saying inability to extend the PIP, DIP, no. No, because they are supplied lumbricus and introitia, we have seen. Inability to extend MP joint, only that will be the answer over here. And that is known as a finger drop. We're not able to extend the MCP, that is known as finger drop. Finger drop. Wrist drop is this thing, and finger, there can be wrist drop and there can be finger extension slightly. But wrist drop and finger drop, you are not able to extend the fingers also at the MCP joint. That is finger drop. Answer over here out of the options will be our option number C. Okay. Lower lateral cutaneous nerve of arm is a branch of. Lower lateral cutaneous nerve of arm is a branch of. Okay, let us see. Let us see, this is the arm and that is the forearm. Right. So you have this arm region A and B. We are divided into A and B. There are two regions over here. And this forearm region, area number C. They are asking lower lateral cutaneous nerve of arm, not forearm. So basically they are asking option number B, this area. Remember a mnemonic over here. Mnemonic is arm, ARM. Simple mnemonic is ARM. A refers to this A, that is axillary nerve. So this area is supplied by axillary nerve. That is upper lateral cutaneous nerve of arm. This area B, that is the lower lateral cutaneous nerve of arm, that is R for radial nerve. That should be the answer in this particular question. And this lateral cutaneous nerve of forearm, that I am sure most of you must be knowing, is musculocutaneous. Just remember ARM, ARM. ARM, axillary nerve, radial and musculocutaneous. We are not dealing with the medial, because medial cutaneous nerve of arm and forearm are directly branches from medial cord of brachial plexus. So they are direct branches from the cord. Okay, just remember this. So just remember this, they are asking you the arm, not forearm. So don't get confused in the exam. Okay, after mastectomy, a patient is not able to extend, adduct and internally rotate. Internal rotation means medial rotation. We have just seen in the previous questions that what is medial rotation, which group of muscles will cause the medial rotation. So after mastectomy, a patient is not able to extend, adduct and internally rotate the arm. Nerve supply to which of the following muscle is damaged? So they're asking us that actually, or you can answer in this way, that this movement, extension, adduction and internal rotation, is a movement of which muscle, right? That should be, and the nerve of that muscle should be damaged in the case of mastectomy when you are doing axillary dissection as well. We have discussed it that during axillary dissections, there are few nerves which are prone to injury. For example, let me remind, intercostobrachial nerves, there is a total cutaneous. Then there's nerve to latissimus dorsi. Then there's your long thoracic nerve. These are the common nerves which might be damaged, though they are avoided obviously, but they might be damaged. So if you look at the options that which muscle will produce these functions and what does the nerve, which we can match them. P major is for flexion, so rule it out. First option is extension. Teres minor. Now teres minor will do medial rotation or lateral rotation. It is attached from the posterior aspect, so it does lateral rotation. We have seen previous questions. Latissimus dorsi. Would it do extension? Yes. Would it adduct? Yes. Would it do medial rotation? Is it attached anteriorly onto the humerus? Yes. It is attached from the floor of the bicipital groove, a lady between two majors. That lady is latissimus dorsi. So it is fulfilling. Plus, nerve to latissimus dorsi or the thoracodorsal nerve is a common nerve passing in the axilla, so that can be damaged. Best possible answer over. Last option is long-headed triceps, again doesn't fulfill the criteria. Now there's the nerve supply of it is damaged in the case of the axillary dissection. Therefore, the answer over here is latissimus dorsi, and these are the functions of latissimus dorsi, and we have seen the other aspects of the particular question. Okay, I hope the solves the answer over here. Froment sign is characteristic seen in Froment sign. We should know that Froment sign, what happens in Froment sign is if you give a piece of paper to the patient and try to say the patient that I'm going to pull it paper, you try to keep it hold of it, then obviously patient is try to keep the piece of paper like this. This movement of the thumb is adduction, adductor pollicis. And we have seen adductor pollicis applied by which nerve? Ulnar nerve. So that is fine, normal. But if you are pulling the paper and the patient is not able to fully adduct, this movement is weakened, he will do what? He will flex the thumb. That IP joint flexion of the thumb, there's only two phalanx, is done by FPL muscle. And that FPL is not supplied by ulnar, it is supplied by the anterior interosseous. So that is Froment sign positive. If you're trying to pull the paper and the patient flexes the thumb, it means the adduction is weakened. So when the adduction is weakened, which nerve are we testing actually? The nerve supplying the adductor pollicis, and that is ulnar nerve, should be the answer over here. Hence, Froment sign is characteristically seen in the ulnar nerve injury, right? So let me show a small image over here. If we have, yeah, that's normal. You can see the adduction of the thumb over here. But in Froment's positive, we have to flex the IP joint of thumb by the FPL muscle, and that FPL is basically by AIN. Just because adductor pollicis is not working, the ulnar nerve is being tested, right? So guys, this is a few of the, I guess, upper limb. Now let us see some of the lower limb MCQs as well. Let's proceed from here. Okay, 16-year-old male received a superficial cut on the lateral side of his foot while playing football. Which cut? A superficial cut. And is admitted to the emergency where the wound is sutured. 4 days later, the patient returns to the hospital with high fever and swollen lymph nodes. Which group of lymph nodes will first receive lymph from the infected wound? A good question. The basic knowledge is being tested. Superficial cut. Location is the lateral side of what? Of the foot. Lymphatics normally follow the vascular pathway. Let us understand it, right? Lymphatics normally follow the vascular pathway. The lateral side of foot, we should know the cutaneous veins in the lateral side is small saphenous vein on the lateral side. On the medial side, the vein is a great saphenous. This vein we should be knowing that it drains into the femoral vein, which is close to the inguinal region, and it also drains along with the long of a lot of structures. The small saphenous vein is on the lateral side of foot. It will ascend, it will go behind in the calf region, it will drain into the popliteal vein. That's it. Now see over here, there was a cut on which side, lateral or medial side? On the lateral side of foot. So those lymphatics should be, because it is a cutaneous, subcutaneous vein, and there is a superficial cut, not a deep cut. So those lymphatics should be around these veins, and those lymphatics will reach first where? They ask you first around the popliteal group of lymph nodes. This should be the answer over here. After this, they will obviously go into the deep inguinal lymph nodes. But first should be the involvement of the popliteal lymph node. Well, if you talk from here, they will directly go into femoral vein. So they will reach into the superficial as well as the deep inguinal lymph node. Right? So apart from the lateral side of foot and the lateral and the posterior part of the leg, the rest of the whole lower limb is being drained up by the superficial part. I'm not saying deep. The superficial part is drained up by the great saphenous vein. Therefore, the lymphatics involved first will be these in the other areas. While in the question they are asking you the lateral side of foot superficial cut should be the area around the small saphenous vein. Let us see the question again. Superficial cut on the lateral side. First involvement should be popliteal, and therefore answer is option number A over. This should be the answer, option number A. Popliteal group of lymph nodes. After popliteal, they will not go to superficial inguinal. They will go to deep inguinal directly. Why? Because popliteal itself is a deep vein, so a deep lymph node. So it doesn't go from deep to superficial. It will go from popliteal to deep inguinal. Okay? Okay, let us see another one. 19-year-old football player was hit on the lateral side of his knee just as he put that foot on the ground. Where was it? Lateral side of the knee joint. Okay. Unable to walk without assistance, he is taken to the hospital. MRI reveals a torn medial collateral ligament, that is a tibial collateral ligament. He was hit on the lateral side. That is why the medial collateral ligament is being broken. But the force is coming from outside, so there is stretching on the inside. Okay, let me just try to show you. Suppose this is the knee over here. The force coming from this side. So there will be bulge or stretching on the medial side. So medial collateral ligament. Then they're asking that which structure would most likely also be injured. So is there any other structure that is very closely associated with the medial collateral ligament that should be injured? And therefore, if we look at the options, we should know. If we don't know, then we should know that medial collateral ligament is fused inside with the medial meniscus, and these injuries are very common combined injuries. So they may occur separately, but yeah, if the injury is very severe, injury to the MCL or the tibial collateral ligament, the same thing, could also injure the medial meniscus. That is the point. So yeah, this is actually sort of fused to the medial collateral ligament. While on the other hand, if we talk of the lateral collateral ligament, is separate from the lateral meniscus via in between there is a popliteus tendon. Just remember that point also, that the lateral collateral ligament is separated from the lateral meniscus by the tendon of popliteus which lies in between, and popliteus tendon is an intracapsular tendon. It is present inside the capsule of knee joint, just like we have the long head of biceps brachia in the shoulder region. 22-year-old football player is admitted to the hospital with pain and swelling over the lateral aspect of the ankle. The emergency department doctor diagnoses a inversion sprain. Which ligament? So there is an inversion sprain, one of the most common things that you see in your OPDs, not in just orthopedics, but in any OPD. Inversion sprain. Which ligament? So just like we saw in the knee, if there is an inversion sprain, the foot is moving forceful inversion. Inversion means the sole of foot will face medially. So when there is a forceful inversion, this stretching on the lateral side. And what is on the lateral of the ankle? You have the fibula and the underlying tarsals. Therefore, the lateral ligaments, the fibular and the tarsal ligaments are the ones which are stretched. So obviously those should be teared. Is there any option with the word fibula and the tarsal? There is a calcaneus and fibular as the option. So that should be a probable answer over here without undoubtedly. While in the lateral side of the ankle, there are various ligaments known as the lateral ligaments. We have the talofibular ligament, which is having an anterior posterior part. We have like this the calcaneofibular ligament as well. If they ask you the most common, then should go with ATFL, anterior talofibular ligament, one of the most common ligaments injured in inversion sprain. Though as there was no option like ATFL, we had to go with the CFL or the calcaneofibular ligament. Fibula to the tarsal, that is calcaneus over here. Okay. In preparing to isolate the proximal portion of the femoral artery, the vascular surgeon gently separated it from the surrounding tissues. Separated what? Femoral artery's proximal part. Posterior to the femoral sheath, what muscle forms the lateral portion of the floor of the femoral triangle? Basic question, what we encounter in our MBBS first year, the long question of the femoral triangle. This question is like that, right? So let us see which muscle forms the lateral portion of the floor. So we should know what are the muscles in the floor of femoral triangle. Just imagine this as the femoral triangle, right? Outside line, this is which muscle forms the lateral border. Suppose I'm talking about the right lateral and medial side, right femoral triangle. This muscle is sartorius. That lies inside, outside. This muscle over here, this is adductor longus, AL. Just lateral to it, we have the pectineus, P. And more lateral to it, we have the psoas and iliacus. PS for psoas major and I for iliacus. These are the floor of femoral triangle muscles. Medial to lateral, you can remember it by APPI. APPI, medial to lateral. Adductor longus, pectineus, psoas and iliacus. So psoas and iliacus should be the answer. Is there any option? There should be. And yes, option number B, the iliopsoas over here, that is the answer over here for this question, right? Okay, so our option number B is the answer. Just a second. Next question over here, and they are asking that a 72-year-old lady is admitted to the hospital with a painful right foot. A CT reveals a thrombotic occlusion of the femoral artery. Very interesting question. Pay some attention over here. Reveals a thrombotic occlusion of the femoral artery in the proximal part of adductor canal. So there is a blockage in the femoral artery in the proximal part of adductor canal, right? Which artery will most likely provide blood supply to the leg through the genicular anastomosis? These are the following options. So there is blockage of the femoral artery in the proximal part of adductor canal, and we should know it is mainly the femoral artery is the only artery that is going distal to the knee with the name of popliteal artery and its branches, because other arteries like obturator artery, normally ends around the knee joint or proximal to it. Now they are saying the femoral artery is being blocked due to any reason. How will the blood reach distally? Through the genicular anastomosis, meaning by the anastomosis around the knee joint. Options you can see over here. What is the probable answer over here? Let's try to understand over here. Oh, we have this image also, right? You see the image, don't worry. Imagine this is a femoral artery going down, then it is passing through the femoral triangle, adductor canal, then it becomes popliteal artery, and so on and so forth, its various branches. This is the region of adductor canal, that's the region of femoral triangle, right? This is popliteal artery over here. Blockage is somewhat over here. This is the region also of the genicular anastomosis. Now what happens is femoral artery will give branches to genicular, but in the adductor canal. So femoral artery will give branches to the genicular anastomosis, but those branches will come in where? In the adductor canal. So that's of no use now. That's of no use now, right? Just a second. So what will be the answer over here? If we look carefully, that this is of no use. What happens is femoral artery will give off a branch over here known as profunda femoral artery that divides into circumflex arteries. And one of them is the lateral circumflex femoral. It will give branch. Lateral circumflex femoral artery. That will show you the image as well. This is the one. Now, if you look at the options and you come to the image later on, medial circumflex femoral, obviously not. Descending branch of the lateral circumflex looks a probable answer. First perforating branches of deep femoral is same as profunda femoris. Perforating branches, they don't participate in that too first perforating in the genicular anastomosis. Inferior gluteal, no, it forms anastomosis around the hip joint. Descending genicular branch of femoral, there is one, but it is already blocked. Now let us look at this image. This thick red color is the femoral artery. This over here is the branches of profunda femoris or the deep femoral artery over here, deep femoral artery. These are your lateral circumflex and the medial circumflex. You can see this thin branch coming down over here, that is a descending branch of lateral circumflex femoral artery. Various femoral artery, this is the thick one, is the femoral artery. And here somewhat it is, imagine it is somewhat blocked over here in the proximal part of adductor canal. This is the descending branch from the femoral artery going to the genicular. This is the site of genicular anastomosis. So the blockage is over here, this artery can't help. So we have to take help, theoretically at least, from the lateral circumflex femoral artery. Hence this would be the answer. That is our which option? Option number B, descending branch of the lateral circumflex. Just try to remember this basic concept. These blockages of arteries, these are the clinical questions. We all know that past few years. And that is a good thing that the core anatomy questions are now clinical. Even that is the use. Else, what's the use of anatomy? I think you have to clinically correlate it. So therefore, we should know these basics in anatomy and the other parts. 32-year-old patient received a badly placed IM injection to the posterior part of the gluteal region. The needle injured the motor nerve in the area. Later, he had great difficulty rising to a standing position from a seated. He was seated on a chair and he has great difficulty in rising up from the seated position. That is the whole question. Which muscle was most likely affected by the injury? You should know which muscle group helps in rising from a sitting position. That's the only thing. So when anyone is seated on a chair, suppose this is the head of the patient, that is the trunk, this is the hip joint, and this is the knee, seated on a chair. When anyone stands, tell me, when the sitting position, which joints are in flex position? This hip joint is in flex position. Yes, it is in flex position. This knee joint is also flex. Yes, knee joint is also flex. Knee joint can be extended as well in sitting position. So when you're standing, this hip joint goes from flexion, when you're standing like I'm standing right now, into a proper extended. So hip joint is going from flexion to extension. So there should be a muscle which causes extension of the hip joint against gravity. Why against gravity? Because here the gravity is pulling it down. Basically against the whole weight of the body, when the person stands up, particularly stands against the gravity, right? So which muscle helps in extension of the hip joint? The main chief extensor of the hip joint is gluteus maximus. And what's the nerve supply of Gmax is inferior gluteal nerve, not superior, it is inferior gluteal nerve. Just remember, it is inferior gluteal nerve, and this is a probable answer over here, right? Okay. So I hope you enjoyed the session. We discussed many questions from upper and the low limbs. That's all. Any other doubts, let me know, and all the best for your exams. Thank you.